Good evening. All right, I know this is the last session. Everyone's in a hurry to go home, so I will try to keep it short and simple. This time, regarding oral placement therapy, I thought I'd focus more on feeding and not so much on speech, but I will talk about how it ties to speech too. So the topic is how oral placement therapy as a technique can help individuals with picky eating or other feeding difficulties. Am I louder now? Yeah, okay. All right. So let's look at what oral placement therapy is. It's a motor-based program. It kind of works on not just auditory stimulation and visual stimulation, but it also works on another component, which is touch. If you feel what is inside your mouth, you will create a movement. That is the basic understanding of it. And it is it's a motor learning program. So the children learn, or the adults learn how to create a movement. All right? And this was developed by Sarah Rosenfeld Johnson in the late 1980s. Initially, it was developed to address speech clarity, because she noticed that a lot of the children, although the language improved, the clarity in speech for 4- or 5-word phrases was really poor. And that is when she started developing this technique. And later on, it kind of broadened its horizons, and you could use it also for feeding difficulties. So let's look at what literature says about children with autism and feeding difficulties. A lot of it revolves around food refusal, selective, restrictive eating, not liking the texture of certain types of food, not liking the look of certain types of food. They're very selective eaters. New food is always challenging. And there is a difficulty sitting for family meals. This is a study done in 2006 that said that sometimes they spontaneously stop eating previously eaten foods. Or sometimes they refuse to eat or touch certain types of utensils or certain types of food. A more recent study in 2017 done in India said that children under the spectrum have more feeding problems and consume fewer number of food items, particularly fruits, vegetables, and proteins, which automatically affected their nutrition. Yeah, there were a lot of minerals and vitamins they were not able to get. So the intervention would not be just one person working on it. There is a multidisciplinary approach, which includes, as you can see, a physician, a dietitian, a speech and language pathologist, an occupational therapist, and a behavioral psychologist. All of them would contribute to helping the child with his or her feeding problems. Now, why is a feeding program important? Well, the obvious reason being lack of adequate nutrition. Everyone needs nutrition. So if you do not have adequate nutrition, it can cause medical issues, weight loss, it can cause obesity, it can cause constipation, and a whole lot of other medical issues. But at the same time, aside from the medical point of view, when you work on a feeding program, you also work on creating some movements that are needed for speech. So feeding is a precursor. The movements that you create during feeding is a precursor for the movements that you need for speech. As Julie just said, speech is a purely motor part of the program. There is just movements involved, right? We're not talking about language here. We're talking about speech. Speech is a purely motor perspective. So we need to look at creating those movements. And who can benefit from a feeding program? Any of these adults or individuals, those with dysphagia or swallowing difficulties, drooling, those who are eating limited types of food, who take a long time to eat. There are some children who take an hour and a half sometimes to eat. Or those who, for example, at 5 years of age are still on mashed food and not able to chew. So when you have individuals showing these kind of issues, you would definitely start on some kind of feeding program. Now, why do they happen? there's a big connection between the sensory difficulties you would see and the motor difficulties. The motor difficulties could be just poor tone, it could be weakness, it could be just a lack of movement that you see. The sensory difficulties, especially the oral sensitivity that a child might show. It could be tactile, it could be proprioceptive. But if anything is wrong with the sensory system and the child is not able to take in that information appropriately and use it, you would probably see these deficits come into the oral sensory system too. Now let's look at how it's all connected. I'll give you an example. Can I use this? Hold on. Okay. So when we sit for a really long time, our legs get numb. Yes? And then we get up. Can we walk immediately? What would happen if we started walking? You probably fall, right? So when you can't feel your leg, you cannot walk. Now, what happens after you start shaking your leg out? What do you feel? Pinpricks? Is it a comfortable feeling? No. So what do? Do you still walk? No, you still won't walk. So if you don't get enough sensory feedback, or if you're getting too much and it's painful, you will not create a motor movement. Yes? So that's exactly what this is about. The sensory system is a very important component that we need to look at. If you get a Novocaine injection when you're going to extract a tooth, do you feel like you're talking properly? No, you feel like, oh, I'm talking like this, right? Because you do not get sensory feedback. And that's exactly what we need to look at. So if you're not getting that feedback, what happens? It automatically starts affecting the motor movements. And if I'm not able to move my mouth, my articulators in my mouth, what are the two functional things we do with our mouth? We eat and we talk. So if those motor movements are not getting developed, what's going to happen? It's going to affect my feeding skills. And it's going to affect my speech clarity. So if a child is, let's say, you want him to talk and you want him to say, I want to go. But he's going like this. Because I don't have any control or fine control over my motor movements to create that clarity. All right? So you can see everything is connected. And even more, like I said, if a child does not like the feel of food in his mouth, a particular texture, what is going to happen? Again, I will refuse that food, right? And at the same time, I won't create a movement. So if you can see, all four circles are connected, interconnected. There is nothing that is on its own. So when we work on a program that is a motor-based program, we are looking at all four components and not just one or the other. Traditionally, what happens? We start work on oromotor skills and speech clarity. We forget the other two, right? So we need to make sure that we are working on all four components when we look at a good feeding program or a good program where we're developing speech sounds as a motor-based program. So what does OPT help with? Since we're talking about this particular technique, what does it help with? So we talked about the four components. So the first one was sensory. So the first thing that it's going to help with is to create some awareness. I have a tongue, I have teeth, I have cheeks, I have a mouth, all of that I can feel inside my mouth. That is the awareness that it will build. And then it will help normalize the sensitivity in your mouth. Now if I'm feeling too much, I don't like the feel of this, will I move? No. They could be hypersensitive to certain input. If I don't feel enough, what am I going to do? I'm going to make myself take things and put it in my mouth so that I feel. So when a child is hypersensitive, you will see that the child is constantly mouthing and putting things in his mouth because he needs feedback. And that's what we need to look at. And if a child is always on alert, he's hypersensitive, always on alert, who's coming near me? What is going to happen? He doesn't trust people around him. He's going to start getting defensive. And he'll start avoiding. Do not come near me, do not come near my face. So you get a lot of tactile defensiveness that builds. The next thing that we mentioned was the motor skills. So when we work on getting some awareness in our mouth, and we're normalizing the sensitivity in our mouth, and we feel how we're supposed to feel, then we work on the oromotor part, or the motor part, which is teaching regular, normal movement patterns, and then creating very controlled movements, right? It's not enough to just create one movement. It is important to create a control movement, because speech is a fine motor skill. You have writing, you all know writing is a fine motor skill. Speech is a very fine motor skill. So if I want to say, I want to go, I need to say it this way and not, I'll go. You won't understand, because I had lost my clarity. Why? Because I didn't have control over my jaw and my tongue and my lips. They all have to work together, they need to work coordinated, and they need to have very fine control to be able to produce these sounds clearly. And that's what we need to teach also. Now, one of the most important things that I will cover again also is the stability in the body. So when we look at these terms that you can see, dissociation, grading, these are just terms that kind of describe the fine control movement that a body needs. Now, if I were to pick up this item, I don't fall over to pick it up. I keep my body steady. I separate my arm from my body, and then I can't just pick it up like this. I need to be able to grade my fingers, control my finger movements to be able to pick it up, right? So this is this dissociation that I have from a larger muscle group. A smaller muscle group goes to pick something up, and that fine muscle movement in the smaller muscle group to pick this up. So there are so many motor movements and fine movements that are needed for speech. It's not as easy as talk to me, speak to me. If a child has issues in his strength, his stability, his endurance, his muscle movement, speech automatically gets affected. Feeding also automatically gets affected. And finally, like I said, the two functional things we do with our mouth, that's what OPT works towards: improving the feeding and nutritional intake, and improving speech clarity. Now let's look at some of the challenges related to the tactile system. If you were to see disorders where sensory processing is a difficulty in the tactile system, you would see that the child might react defensively to touch. They might have motor planning problems. If they're hypersensitive, as you can see, they might have feeding problems which include sensitivity to food, and that's exactly what we're discussing today. Food textures, temperature. So what happens? They don't use their lips and their tongue appropriately, which again affects good feeding skills and speech. If they're hyposensitive to touch, they will constantly seek stimulation. All right? They will overstuff their mouth. They could be messy eaters. They don't know saliva is building in their mouth, and so they start drooling. Again, they have poor use of lips and tongue. Again, the motor component is not coming in, and so you see a direct impact on good feeding skills and speech. So you can see how sensory ties in with the motor. It's not an individual thing, it ties in together. It needs to work together for you to have the end result of good feeding and good speech. Now, when you do a feeding program, as much as possible, we need to keep it a very positive environment. When I say positive environment, it does not mean that we show the child a YouTube video while we feed them. That's not really what I meant. Because when you do that, that's not really building the skill the child needs. That is something happening, I'm watching something is just being stuffed into my mouth. I have no conscious idea of what is happening inside my mouth, what movements I'm creating, and if I don't have that knowledge, I am not going to use it to create a sound later. So when I say a good environment, a calming environment, it does not mean distract them with a YouTube video or distract them with the phone. It means it could be interactive, it could be where you are a lot more calmer than the child, even if the child is very upset with you, and you being more calm about it and saying, it's okay, We're just going to try. If you don't want, we'll go on to the next thing. So that they feel and they trust you. And you're not the enemy. Otherwise, it becomes a very, very unpleasant experience. And every mealtime will be an unpleasant experience. Till the end, and what happens in the end? The parent will start feeding the child. I want to finish it off. He needs to go. So within 15 minutes, the meal is done. But what happened in that? Nothing. The child just got something in his mouth. But did any skill develop? Absolutely none. Yeah. So like I mentioned before, stability. Before you start any kind of feeding program, and even if before you start a speech program, you need to look at stability. Because the stability in the body will allow for a lot of mobility in the mouth. We don't think of it that way, but as you can see in the pictures, the children are seated at a 90-degree angle. The feet are always supported. There are no dangling feet there. All right? Whatever the age the child is, there should be no dangling feet. If any of you try sitting with your legs up and stay in that position, you will see what happens to you. You can try it out if you want. For a minute till I tell you, please try it. Put your legs up and keep it up till I tell you to put it down. And you tell me what's happening to you. You can shout out your answers. You want to put it down, why? It's tiring. And what does that make you do? What happens to your body, your torso? What happens to your core? You're going to go like this, like, oh gosh, right? Yes? That's exactly what's going to happen to the child, because I see a lot of times the parent putting the child up on the dining table or on a big chair, and the feet are dangling all over, and after 5 minutes the child is like itching to get out of that chair. Why? Because he's tired of sitting that way. We can't do it. Do not expect the child to be able to do it. They need to be always seated appropriately with feet stabilized, right? If the child does not like sitting on the chair and does not get adequate proprioceptive or tactile input, you can put them on a beanbag chair. That's also possible. You can get them to sit on the floor cross-legged, but they need to have back support. So it's not that in the center of the room that you just put them against the wall so that they have back support. If you didn't have back support, you'd also start doing this. It hurts. You have to keep your body straight for so long. You can't do it, right? So you need to have back support and you need to have feet support when you're looking at stability in the body. Now, these are the things that we do if there are sensory difficulties. If you see that the child is hypersensitive, hyposensitive, defensive, fluctuating sensitivity, or even a mixed sensitivity, we'd work on those sensory difficulties using sensory massages. Now, when I say we work on it using sensory massages, that does not mean I go to the child and say, hey, how you doing? And start doing all these things in their mouth. That child is going to run away very fast. If I came to you with an instrument and say, okay, put it in your mouth, you'd hate me for the rest of your life. So we're not going to do that. So for a child, especially who's hypersensitive, who's tactile defensive, you will not go straight out and do that or put a tool in his mouth. You will first build trust. The child needs to feel safe, that you are not going to harm them. If a child is tactile defensive, you can give them the tools. You can give them cream and say, for example, oh, can you just rub it on your leg? When they feel that it's safe, they will do the rest. They will allow you to touch their face. Do not go near their face unless they're allowing you to. Because I know a lot of people who start to work on oromotor work and the child is crying 45 minutes in the session. Do not do that. It is a negative experience for the child, and the child will never trust another person after that. Now, if the child is hyposensitive, he loves the tools. Bring it on. You put it in his mouth again and again and probably fight you for it, which is good. You can do a lot of work. But you also need to understand it is a structured program. A lot of times I see the chewy tube. I will show you an example of that. The chewy tube being used non-stop. It's like, oh, he's mouthing. Here's the chewy tube. I'm sorry, that's not the way to use the chewy tube. The chewy tube does give input, yes, but it has to be done properly. Any tool you use, you need to have an idea how to use it. Don't randomly use it. Because if you overstimulate the child, it's even worse. We need to just stimulate the child, not overstimulate the child. And sometimes when you give them the chewy tube, they learn wrong movements. They learn movements like this. This is not going to help speech clarity. None of us talk like this. So if your jaw is so unstable, you're not going to be able to talk clearly. So please be careful of what tools you give to children. Coming back to this, the other things that we vary, you can see the third point: taste, texture, temperature. These are the 3 T's that help us normalize the sensory system. For a child who hates textures, we won't start with texture. We will start with taste and temperature. Get them into allowing a variety of tastes in their mouth, and then we will start working on texture. So there is a structured way you go about it. These are some of the tools that you can use, everyday items that you can use outside the mouth, on the oral cavity. These are some of the tools that we use inside. You might be familiar with some of them, but these are some of the tools that you can use. And this is just an example of how the massages are done. Just to show you what sensory massages looks like. So it can be done with your hands, it can be done with bean bags, with some texture, it can be done with the Z-Vibe. Right? And all of this helps create that awareness and normalize the sensitivity in your mouth. This is a question I ask in every presentation. Which do you think is the most important articulator? Which is the most important organ in your mouth for speech? And that's the answer I get all the time. So, let's look at this. Now pretend this yellow circle is the finest acrobat in the whole wide world. No one can defeat him. But those red circles there, they're not well, they're sick, they're weak. What's going to happen to the yellow one? If they fall, even if you're the best acrobat in the whole wide world, if those red circles move or fall, that yellow is going to fall, yes? Now, this is the pyramid we follow. It is not the tongue that we look at first. It is the jaw. The jaw is the most important articulator we need. Then it's the lips. And then finally, it's the tongue. The tongue is the finest muscle we need to move, right? But that's not the first one we should work on. And a lot of time, traditionally, I have learned it for a long time, speech therapy, we work on those tongue movements and lip movements, and we don't even look at the jaw. And if you don't look at the jaw and the amount of strength it has or the amount of movement it has, the lips and tongue are not going to be able to do their job. So if the jaw is unstable or it has poor strength, it will create a lot of abnormal movements, right? Some of which I showed you where I move my mouth to either side. You will see children doing that. Or jaw jut, where the jaw moves forward. These are not movements we want because this will affect the clarity directly. And if you see the ones ticked in red, this is how it affects feeding. So if the jaw is unstable, it will still affect feeding. Poor chewing, poor manipulation of food, prefers only soft food, will not take harder textured food. Messy eating, inability to eat from a spoon. If I eat from a spoon, I'll eat like this. Or bird feeding kind, just push that spoon in. You're not able to create those movements if the jaw is unstable. And what does that result in? Poor nutrition finally. So we know that the jaw is important, so we start work on that. We create fine control movement of the jaw. And what does fine control movement help with respect to speech? Can you think of sounds that it will help with? Yes, all your vowels. And if your vowels are unclear, 90% of your clarity is gone. This is how important the jaw is. So we need to create good control movement. We need to work on that strength, the stability, all right? And we need to make it so automatic. Walking is automatic to us. We don't even think about it. We don't think, oh, I have to put my right leg, then I have to put my left leg. I don't think, because it's an automatic movement. The same way, speech, being a motor movement, has to become an automatic movement. Otherwise, the child always has to think, wait, I have to say papa, so I need to close my lips first, then I need to open it. We don't have that much time. We don't think so much when we talk. So if you want the child to be able to create movements like clearing a spoon or chewing food, these movements need to be repeated so many times that it becomes automatic. These are some of the tools that are used to develop the jaw, the lips, and the tongue. Each tool has multiple functions. It can be used in different ways, but all of it at the end of it is to create that good motor movement. And if there are feeding difficulties, and this is the whole presentation is basically about this, we would work slowly on the feeding too. Now, if children are very defensive about food, don't like us coming near them with food, we would first work on the motor program without food being involved. And once they get more confident in their movements and they're more secure, then we'd probably bring food in, right? We might try then in that case for children who are eating mashed food. I wouldn't start with solid food yet. I would look at changing the textures a little here and there, getting some movement, for example, with the chewy tube, and then maybe putting food at the molar area to see if they can create that same movement and bite and chew. So as you can see here, you can see that all of these activities teach placement of speech sounds. So this is where I'm going to connect feeding to speech. Now, if I was eating from a spoon, what is the movement I need? What are my articulators doing? My lips are closing. My tongue is going back. It's not doing this. It's not doing this, right? It's going back. My jaw, it needs to move in a way, it's not this, it's a very controlled movement. So all three articulators, the main articulators, are moving functionally for an activity like spoon feeding. And if you have lip closure, what are the sounds that you can try and create or encourage? Purr, burr, These are the sounds. If the child is eating food from a spoon like this, is the lip being used? No, the lip is not being used. So what's going to happen? I'm not going to create purr, burr, more, or I will create it this way. Ta-da-na. Ta-da-na. I will create a compensatory pattern. Because you want me to say it, fine, I'll say it somehow. But this is the way I'm going to say it. Ta-da-na. And what's going to happen, it will cause a structural change in the lip. The lip is going to go up, up, and stick up there. And your teeth are going to protrude. These are structural changes that happen if the articulators don't do what they're supposed to do, or the muscles don't do what they're supposed to do. All right? Another example, sucking from a straw. We take it as a vegetative skill. They need to learn how to suck from a straw. But why? To take liquid in, yes. You're a speech therapist, you're not allowed to answer. Joking. Yes, so when you suck from a straw, you are closing your lips, but more than that, you're protruding your lips, which helps with what sounds? Ooh, oh, wuh. So there is a direct relation to feeding and speech. What movements you create in feeding, you get those same movements in speech. Okay? So it is very important to tie the two together, and that's what I talk about, those 4 components, and it's not one or the other. So as you can see, these are some of the activities which will teach, like I said, placement and create very controlled movement. So, in conclusion, OPT, again, is not the end-all. It is one component of a program. It is not the only program that you should be doing with the child. I know a lot of parents who come to me and say, I want speech. I want you to do OPT to get speech. As you heard Julie say, just the presentation before, speech is not the end-all. Communication is what we need to look at. So communication first, then we look at developing the motor skills that are needed for speech, and then we take that further. All right? It's not speech first and then communication only through speech. It cannot happen that way. So when you do a program, OPT is a small component of it, which is done parallelly with the other programs that you're doing. So what we look at is, does the child have any issues? Is the issue a sensory deficit, a feeding deficit, or a motor deficit? If it's a sensory deficit, we'd work on it. We would give activities to normalize that sensory system. If it's a feeding deficit, we'd work on activities that help improve that feeding as a precursor to speech. And if it's an oromotor deficit, we'd work on those motor movements, and you saw some of the examples of how we can do that. All right? And if none of these are there, traditional therapy works. Look at me, do what I do. Look at me, say what I say. Works beautifully. But if that is not working, then you'd have to look at these components too. All right? And that's all. Thank you.